Now we're going to have some provocative fun. We're going to have a debate, the second edition of Quips, Quandaries, and Comebacks, a quality debate. This year, our debaters will be arguing for and against the motion, accountability hinders improvement. And you're going to decide the winner. Or as Donald Trump would say, you're going to say who's the losers. Now let's get to it. One thing we would like to note, full disclosure, that we assigned these positions. And not everybody up here is necessarily going to believe everything they say. And what we might do at the end is get your vote on the Best Actor Award to see who is dissembling in the most compelling and persuasive way, and whom you would hire as your own personal liar if you needed to have one. So, the format is this. There are 2 speakers for the affirmative and 2 speakers for the negative. Each of them will start with 2.5 minutes. So we're keeping this short. So alternate 1, 1, 2, 2. Then, as a twist for this year, there is an 18-minute session whereby the moderator, moi, will be asking them questions to elaborate on their positions, explain their contradictions, urge them to provoke and insult their opponents, and generally, if there's insufficient conflict, to heat it up a little bit. But in all seriousness, this is fun, but this is also serious, and I think by the end of it, we should have a very good idea of some of the issues that surround the issue of accountability. So while we chose these sides, and there's some mirth involved here, it's really quite serious. I'm going to introduce them to you now on the for side, and I'll just introduce them all at once so they can immediately just go one after the other in the service of time. Arguing for is Lakshman Swamy, an internal medicine resident at Boston Medical Center and tomorrow morning's plenary speaker. His partner is Linda Dempster, the Vice President of Patient Experience in Fraser Health. Give it up for Linda. Arguing against, that is, people who are in favor of accountability in healthcare, are David Sweet, a critical care and emergency medicine physician and the BC Patient Safety and Quality Council's clinical lead for sepsis. Woo! No conflict of interest there, as the Quality Council puts in a ringer. And then to his left, in case you didn't remember from this morning, is Jim Easton, whom you might recall gave a wonderful speech this morning, full of tips on accountability, actually. And he's the Managing Director of Healthcare for Care UK. So give it up for Jim. Yes. I believe the clock will be telling you where you are, but when you get close to 2.5 minutes, I may give you a little bit of a signal here. So without further ado, take it away, Lakshman.
Hello, everyone. Ooh. Good? Are we ready? Can you hear me? No? Are we there? No? No? Not yet? I can talk really loudly. Okay. Notes used to be our story, narrative, but yo, replaced with copy-paste. Now a bloated ransom note. Me, I'm at the bedside, focused like a laser beam. On the patient? Nah, I'm treating the computer screen. Thank you. That, not my words, that was Z-Dog MD. He does it much better than me. Google him. And that's what accountability is in practice. There's a lot that you're going to hear about how beautiful it is in theory, but let's look at what it's like in practice. And there's a reason that meaningless abuse, meaningful use, is going away in the States, because accountability in practice is fundamentally flawed. It's flawed because it counters the principle that everyone in healthcare wants to do the best for their patients, except for an extremely small minority. We know this because we know our colleagues and we believe in them. And we know from the front lines that accountability always interferes with the time we have with patients. Accountability isn't something that's done from far away. It's us. It's us on the front lines that provide the data for accountability. And that is 1,000 thunderous clicks every hour, right? That is me staring at a computer screen instead of talking to my patient. We have to spend our time documenting that the patient already got their flu shot at an outside clinic, And it takes like 5 minutes to do that when I could have actually been helping them with their flu symptoms or whatever it is. There is no perfect world in which the burden of collecting that data that feeds the beast of accountability with its endless appetite is displaced. It will always fall on the backs of providers. Unless you're another provider just like me sitting in my room with my primary care patient, you don't know if what I'm doing is the best that can be done or not. You can't value the work I do because you're using broad strokes that don't apply to individual clinicians but may apply well to a population. While you're dinging me for poor colon cancer screening, why don't you reward me for the number of patients I got housing for, or the time I spent counseling patients who are crushed by societal determinants of health? Accountability can't capture these things, and it never will. In all forms, it ends up being carrots and sticks. Don't let them convince you that it's more than carrots and sticks, because that's what we feel. That's what we know it to be. It presumes that we're bad people who need those carrots and sticks to care for our patients better. It just doesn't make sense. So I would challenge the other side to prove to us that accountability never hinders healthcare improvement, because it so obviously does today. Thank you.
Thank you. Although I'm impressed with the rap, I don't know if you've heard Jim speak, but he has a British accent. I'm sorry, but we've already won. He's the smartest guy in the room. So I'd like to start with a couple quotes from John D. Liem. Accountability separates the wishers in life from the action takers that care enough about their future to account for their daily actions. And accountability is the glue that ties commitment to results. The common theme of my position is that accountability insists on action. Accountability does not hinder improvement. Accountability is required for efficient quality improvement and to ensure that baseline levels of quality are met. Accountability in healthcare ensures that the absolute minimum accepted care occurs that is required for our patients to be safe. If there is no accountability, there are no checks and balances for quality. Accountability will instantly raise the bar of what is acceptable healthcare delivery and will improve the system as long as the targets that people are held accountable to and those that are chosen to be accountable are well thought out and appropriate. You'll see with accountability comes commitment from senior leadership and therefore resources. Additionally, it will demand efficiency, it'll demand focus, and more importantly, consistency. Taking the example of aviation, which is often compared to healthcare, is that it's complex and high risk. Would you fly in a plane or an airline which no one was accountable for the safe completion of your flight? Or would you just trust in unaccountable attempts at improving safe journeys? The United States Joint Commission published in New England Journal 2010 on the utility of accountability measures and quality improvement. There is a reason why they collect and hold people accountable to over 57 inpatient measures, 31 of these of which are publicly reported. It's because it works. With the addition of accountability measures in the US, there have been drastic improvements in delivery of key therapies that are evidence-based. And the fact that they have displayed degrees of improvement and greatly narrowed variation over short periods of time, which have never been seen in US healthcare. In the first decade of the 2000s, 3,123 hospitals were reporting 22 accountability measures. This assessed about 12.5 million opportunities to provide elements of evidence-based care. The percentage of hospitals who were able to achieve 90% success on their accountability measures increased substantially from 20.4% in 2002 all the way up to 85.9% in 2009. I ask you, would even a fraction of this improvement occurred without these accountability measures? To conclude, accountability is required for healthcare, for safety, and will stimulate and ensure quality improvement.
Great. Can you hear me? So first of all, I just want to say that it was very nice that we all got to have lunch together, and Dave looked at my notes.
Dave.
So I want to start by saying, when was the last time you were held accountable for that positive outcome? Never. Accountability connotes the fear of punishment or penalty, and to penalize people has synonyms such as castigate, chastise, discipline, fine, to put at handicap, but also the others like throw the book at, put at a disadvantage, Is that what we want to do to our people? The synonyms for castigate are bawl out, beat, berate, excoriate, love that one, flog, rail, scorch, scarify, I don't even know, I've never even heard that word before, whip, pummel, and the best one being fulminate against. To the contrary, antonyms are aid, assist, compliment, exonerate, praise, reward, guard, the final being help. Is that not what we do as caregivers? It's fundamental to our core, and why do we want to do the same for each other? If helping and assisting is truly fundamental to what we do in healthcare, then why would we impose punishment and blame? We are responsible caregivers. Imposing penalties and punishment will lead to the exact opposite of what we are trying to achieve. Thank you.
Thanks, Linda. Good work on the thesaurus there. Geez, we've never met, really. We've never met. My role on the team is to be the young, dynamic, good-looking one. And I'm a little spaced out in the time zone, so I'm not thinking that straight. So I'm just going to go for it. So targets are great, aren't they? You know, what's not to love about a target? It gives you something to aim for. Hell, it gives you someone to aim at. It's fantastic. An inspection, what could be more bliss than leaving the horrible, mundane every day of your work and going to visit someone else's and telling them what they're doing wrong? It's so deeply rewarding. And what is more pleasurable in this grim life than blame? You can take a complex, difficult, subtle situation and cut through all that and point your finger at someone and say, you suck.
You know what side you're on, right?
Just saying.
Which I think is basically the argument that Lakshman and Linda were making. And there's no point arguing against the wrong kind of accountability. Donald Trump is not an argument against democracy. A double whipped cream vanilla caramel latte is not an argument against coffee. It's no good arguing against the wrong kind of accountability. We want the one that praises as well as holds to account. It's a falsehood that you're portraying, and more than that. Accountability is at the heart of what it means to be a professional. That you take enormous risks and interventions with people's lives, and you're prepared to answer not just to yourself, but to your professional body, to your professional standing, to your community. How much have we talked about that today? For what you do, provided it's done in the right way. And accountability is at the heart of quality improvement. It's, 30 minutes. Measurement. Measurement. There is no quality improvement without measurement. That phrase is not, there is no quality improvement without secret measurement. Not without measurement. So let's do it, and let's do it right, because done properly, it's right at the heart of the journey that you are leading today. Thank you.
Brilliant. Brilliant start, and we've got lots to argue about. So let me address taking off from that.
Vote now. Vote now.
Well, this debate's getting out of hand already. So let's. I want to get Jim and Lakshman to have a little exchange here. So does nothing in his argument resonate with you, Jim, about the burden that is imposed, and that yes, you may be arguing that you want the right kind of measurement and the right kind of accountability, but to paraphrase what he may say, so a bunch of bureaucrats like you get to make his life hell with all these measures, and he's the one who wears it. So any common ground here, do you think?
So number one, what's not to love about that? And number two, the thing that Lakshman said, which is a classic bright guy slipping in a little untruth, is that it's inevitable it's done badly. So I would rebel more than you to someone controlling my life like that. But is it inevitable it's done badly? No. That's why we're in the room.
Lakshman, what do you got to say to? They just called you a liar.
Sure. So again, I would
to his face.
True. Yeah, I would say be very careful about what you're hearing on the other side. We've got dashing good looks, and on the other side, an English accent. It's all a sham. So listen, here's the thing. I want to make this point again. It's about proving to me, as a clinician taking care of one patient at a time, that accountability will never hinder improvement. Yes, maybe it can be done perfectly in this one instance with this one thing, but that's not how it plays out. Do we really think it's going to turn into some magical world where all of the accountable measures everywhere that are employed in every spectrum of clinics, hospitals, everything are all wonderful and perfect? No, all of us know that not to be true, right? We all know it won't play out like that. Some of it might work a little bit, but in the end, it will all, as a whole, really hurt us. And you may not see it. You may not see it when you look at the numbers, but some of the things that we measure are not worth measuring, and really not everything worth measuring is measurable. So it doesn't work.
Jim, I'll give you 30 seconds. Do you buy in any of that?
I feel like that was his talk this morning.
If you believe that what matters isn't measurable, then you don't believe in quality improvement.
Ooh. Okay, sorry, I wasn't mooing out loud, was I? Now,
No applause for that?
That's good. So, I'm going to turn it to you, David. Linda gave a very elegant linguistic analysis, and I'm inviting you to maybe provide an anti-semiotic rebuttal. So, what do you think of her language analysis? And the various synonyms for accountability are quite gruesome. So, do you think that the word is just a gloss on underlying hideous attempts to cajole, corral, and beat up the workforce? Or do you think that she maybe left out a few on her list of possible synonyms?
I'm sure there's a couple that she missed. But I think, Linda, for what you were saying, you focus so much on the negativity. Accountability does not necessarily have to mean a negative reinforcement. As you alluded to, there's some positive reinforcement techniques, and I think we've all seen in our quality improvement projects that with positive reinforcement, often you're going to end up getting more and more buy-in and work done when you have positive reinforcement rather than negative. And the analogy I would make is an addict. When an addict fails at what they do, there's been a shift in being punitive to more treating it like a disease, and they may need help. And I think if you're going to use accountability as a method of maintaining quality, that's got to be the optic you use. So if someone or a group are unable to reach the targets that you're shooting for, maybe it shouldn't be punitive and they shouldn't have resources taken away from them, but there should be a service that provides resources and help to help them achieve that goal, rather than a punitive nature that you suggested.
And Linda, I mean,
Thank you.
Linda, I presume as a senior leader in the health system that you've walked the talk of your own argument and used accountability to abuse your staff and otherwise humiliate people.
All the time.
So, but of course that's not the case. So when David counters like this, are you making the argument that the same as Lakshman said, theory and practice are always going to diverge, and we are still in the harm phase of the accountability movement?
I think that's part of what it is. I think when we talk about the big system of accountability, we're talking targets, we're talking multiple indicators. And really at the end of the day, and then we put in disincentives that go along with those. So then we start penalizing people or we take money away from them. So what motivates people is not necessarily those extrinsic values, it's those intrinsic values. And what we need to do is to support people with actionable, timely data. We're being held accountable to data that's 2 years old. So that's a little difficult. Timely data plus information sharing capabilities rather than external values such as financial rewards. Those are misaligned in our current system, and what really truly motivates people is we need to be focusing on systems that naturally leverage those intrinsic values and actually help people to support people to get there. So I'm going to tell you a little story. Is that okay? So here's a true story. There was a nurse and a dietitian who came up with a very innovative idea around how to reduce malnutrition risks for patients on the unit. Imagine this is the Vinyl Cafe now. So the manager noted that this initiative was wonderful and that everything was just fantastic and things were going very well. The director got a hold of it as well and thought it was a fantastic idea. So let's start reporting on it at a quality committee. They set targets. They actually produced standard templates. There were standard PowerPoints. They had a reporting schedule. There was targets set. Then it went up to the senior executive team. And finally, it's sitting on the scorecard. It's now being publicly reported. The nurse and the dietitian were now spending so much time reporting on what they were doing rather than focusing on the quality improvement that eventually they had to stop doing the intervention because they didn't have enough time to continue on. That's my point.
Wow. Good story. Now, let me punt this back to Jim.
Did you guys rebuttal there once? There's one little comment. So what we're hearing here often is not necessarily that it's accountability that's the problem. It's the choice and the number of targets and the way that information is being collected. So obviously we need more automation of our data collection, and we need better choice of target and research into what targets are actually giving us as far as information and how it's influencing quality.
I've never seen accountability not deployed as anything but a bazooka.
But that's the United States, right?
I hear a wall being built at the border.
We'll get you to build it.
Exactly. So Jim, pick up on Linda's point about intrinsic motivation. So in a world where everybody had got religion about improvement and were really intrinsically motivated, could you do away with some of this extrinsic, external accountability stuff because on the assumption that people would figure out what to measure? You could generate it from the ground up and they would use it for improvement in their own jurisdictions. Maybe comparison is no longer of great interest when people are motivated towards excellence regardless of what others are doing. So is accountability just a temporary stop on the way to the promised land, or do you think it's here to stay in an external sense?
So my understanding of improvement nirvana is one in which accountability would be stronger, in which there was more measurement, more of peers and colleagues and communities and patients holding each other to account for delivery in a positive way that was designed to encourage things going forward. There is no secret route to better. And I was taught recently by something I wish I'd known for my whole career, which is whenever you're presented with a statement, like the one we're debating today, but many, many that you come across in debates about healthcare, how does it sound if it comes from the mouth of a patient? How would it sound if it comes from the mouth of a family member of a patient who we'd harmed? And I don't believe there are many of those people who would say accountability hinders improvement.
So, Lakshman, I'm assuming you dispute that account.
Well, let me defer for a minute.
No, you go ahead.
What, do you want to talk about the?
Yeah, you go ahead.
Okay. So, in that awful country to the south, there's a guy who I heard his name mentioned this morning, Don Berwick, and I feel like he was mentioned in a really nice way, saying how enlightened he was about all this. And what really struck me about his all of the work he's doing right now, all of it, his keynote at the IHI National Forum, the papers he's written since then, every talk he's given has been built on the cornerstone of less measurement. We need less measurement across the board. Reduce it by 80%. We measure too much to be measured. And I mean, I think that if you ask patients about this, they'll tell you, will that mean the doctor will start looking at me again? And that's why patients and families will absolutely embrace this idea.
So I think it's great for Lakshman to finally make my argument. So Don argues for better accountability, for more focused measures, a smaller number, less intrusive, but the right ones to hold ourselves to account for, not for zero measurement, for zero accountability.
I just don't, fundamentally, I think that it's not possible for the machinery of accountability to be so specific that it can target those specific targets that work so well. Not only because it is a machine and it will keep finding new targets because they look great on paper, but also because the targets are so different for every local environment. And that's why accountability is accountability and QI is QI. They're two different things.
I would say, despite we're supposed to be arguing, I couldn't agree more.
Oh, come on.
There's a reason why it's called QA, QI. They are two separate things. QA should be done by a single department that's looking at measurement, it's looking at iteration, looking at the information they're getting, and feeding key accountability measures back to leadership. At the same time, while collecting a more vast amount of information that then is given to the QI side, which is a different set of individuals or organization that's working at true quality improvement to get as many evidence-based practices in place as possible and not worrying themselves about the quality assurance side. So there are two different components here that I think work in harmony.
Okay, but
you need the assurance.
I need to press the negative side a little bit here. I think what these folks are saying is the signal-to-noise ratio is always going to be terrible. And their argument is, if I may make it for them, it's always like that. There's never been an indicator exercise that didn't get out of control like a cancer. So this is the way of the world. So tell me what chemotherapy that you've got going there that actually in practice has managed to pare down this nightmare of metastatic data into something that people can actually use.
That was good. That was good.
I think I might just read a list of synonyms for cancer. So my answer is simple. My answer is simple. Go to any poster presentation for any fantastic quality improvement conference. And that's what you'll see. You'll see people who've chosen to drive wonderful quality improvement with public explicit measurement that they held themselves to account for. And I go back to the same thing. So the key, so accountability can be awful and it can kill a thing. The argument that it's inevitable is a dismal argument because we want it. We want the right kind to drive and incentivize our work. And if we haven't figured out how to do that everywhere, then we should. And I'm an organizational leader, and I think the most important things I do very often are stopping measurement. So I spend a lot of time trying to have less for people. But then when we have the reduced amount, to be really serious together about making use of it to drive improvement. So there is so much agreement, of course, here, which is about not having the wrong kind of accountability. But it would equally kill improvement if we swung it all the way the other way and had none.
So on this side, I think the challenge for you is to say, okay, you got what you want. We're done with the big mega data, and we're rolling back the clock. So how do you know that you're doing good work? And if you don't like the capital A accountability, what's the small a accountability, and how would anyone know? Why would anyone go and visit your medical office given that you hate data?
No, we didn't say that.
So I think what I would say to that is that it's not fair to make a synonym between accountability and data or accountability and transparency. Those are not all the same thing. I think if you can harness people's intrinsic motivation in healthcare, we will be transparent with our numbers. We don't need someone to fine us for not doing that. We don't need someone to fine us when we are transparent and our numbers aren't great. And instead of helping us, they fine us. They fine us until they find us out of a hospital. That happens in America. So accountability is very dangerous when it comes from on high. I think it should instead be all about finding the ways to support providers who are busy, right, in giving them the tools to apply quality improvement and giving them the ability, the room for innovation. That doesn't happen when someone in an office far away from my clinic says, why aren't you meeting this A1C target? Because my patient is homeless and using heroin. I'm working on that part.
But isn't that the same? Isn't that the same as the criminals saying, you know, we should decide our own sentences and we get to pick the food, because when you people do it, it's all wrong. You don't understand my needs.
Prison reform. No, I think these aren't the same at all, because I think transparency is there. I think there's a role for overseeing organizations, but that role shouldn't be punitive. And I think in its absolute sense, accountability means punitive.
Disagree.
So, Linda,
Yes.
have at this. I mean,
Okay.
you're right at the vortex of this, because you are the champion of the patient experience, right?
Yep.
Which is a different kind of accountability that, frankly, if we applied it, everyone would be failing, pretty much, right? I mean, a lot of the time. I read the data, those crummy data, but they're data. So how do you transform this into something that you could live with?
So I think what we were proposing is that we would have what would you rather have, a relentless focus on accountability or a relentless focus on improvement? And so we propose that we would focus on the ability to influence that and outcomes before they happen. Accountability by its very nature is almost retrospective. So we're looking at data, as I mentioned before, that's 2 years old and being held accountable for that. We want to, and I think Jim alluded to it this morning, we need to be more upfront. So we need to build in systems that we would do this upfront. There was a study that was done that showed that that physicians view favorable incentives, and I think that's the other piece that's tied to the accountability argument, is these incentives. And I would argue that many of them are disincentives because they actually contribute to gaming of the system. We focus on the data as opposed to the patient. And we actually, what Lakshman and I coined was, we end up in a whack-a-mole situation where you don't realize that this is an entire system that we're working with, and you push on one end of the, who said the tube of toothpaste this morning? So you push on one end of the tube of toothpaste, and then, or the gopher pops up in another area.
Okay, we got to stop you there. We're at the end of our free and open inquiry round. And now we've got concluding statements, 1 minute per. Just we'll go in the same order, or if you guys decide which ones you want to go first, and you guys as well, go 1, 1, 1, 1, and then we'll get a vote.
You want me to start? Okay. So, in summary, accountability as it currently exists stifles innovation, it supports gaming, it does not leverage our intrinsic values as healthcare professionals to want to improve. It causes system-level whack-a-moles. It is penalty-focused. We're held accountable to data that is old. We need to provide local, actionable, timely, relevant data, some tools and resources, plus a little bit of dedicated time for clinicians to work together, and they'll do it on their own.
Should we go?
You go.
Yeah.
Yep.
I've heard many comments about the intrinsic natures of professionals wanting to do the best work, which I agree with, and I think that's why everyone, for example, is in this room. But we still need to make sure that those people are providing good work despite their intentions, and that's going to require some degree of accountability. Gaming can occur, which is the first, we just brought that up, and that's the last phrase here, but gaming is when you incentivize targets that are not believed. So we need to focus on accountability targets that are believed by the practitioners, and they have to be involved in the decision. I think in the last sort of 15 years, we've seen more and more investment into quality improvement. I don't think we're there yet. I think we need more investment by our health authorities into quality improvement. And specifically, we need more investment in resources into researching our target measures and making sure that they're providing us the information we need to improve the quality that we're attempting to provide. Thank you.
There's a reason that the great proportion, the great mass of providers out there, even those who are dedicated and embrace quality improvement, react with the same visceral visceral response to accountability. There's a reason. It's because it doesn't play out that it works. And I totally believe in transparency. We want all of that, and I think you can have it without accountability. I want to give you the example of peeing on walls. So in India, there was this problem where people were peeing on the walls, public urination. It was a huge problem. And they could have gone about it by holding people accountable. They could have held the person who's in charge of washing the walls be accountable and say, fix this, innovate, do something brilliant, or ticket people, or pay people to use the bathroom. None of that would have worked in India, right? No, healthcare is just as messy. What they did instead was paint pictures of gods and goddesses on the walls. It doesn't even matter if that's your religion. No one's peeing on those walls anymore. Accountability does not allow for innovation, and that's what we need to see. Thank you.
Well, everyone in this room has a tough, complex job, and that's why you sometimes abreact against the idea that some nameless person is in an unfair way holding you to account. But although your jobs are difficult, you have one amazing special privilege that other people in your society haven't got. And it's this, that you know if your mum was ill or your kid, which doctor you would have treat them. It's because you have privileged access to information about the relative quality of delivery from healthcare professionals that you know. And you think it's great, glad you do, but you think it's okay 30 minutes. You think it's okay for you to have the information, but not the people we serve. And I disagree. I think everyone has a right to the same level of knowledge and choices about relative performance. And if we're not to kill the precious thing we run by doing that, then the kind of accountability we need, turns out, is exactly the kind that Linda describes. One that isn't punitive, that doesn't kill the thing that matters, but neither does it regard it as privileged and special information that only we can know the quality of healthcare that we produce.
Right. Well, we ended up on almost deeply moving notes. That was great. So now we're going to have a vote, but it's a very peculiar kind of vote, partly because I blew my assignment. So what I want you to do, and this is a little tricky, if you, before the debate started, agreed with the proposition that accountability hinders improvement, and you now no longer do, that is, you've changed your mind, please raise your hand. That was too complicated.
This is how accountability
Well, that's 20 minutes of my life that's never coming back.
If you so I'm asking you, if anybody who previously thought accountability hinders improvement, and now you don't think accountability hinders improvement as a result of this debate, please raise your hand in the audience. Yeah, we got some people who changed, yeah, right. Okay, now the other way. If you previously thought that accountability does not hinder improvement, but now you think it does because these guys were brilliant.
He said it.
Change your mind. Did you change your mind in that direction? You now believe that accountability does hinder improvement.
So we had no effect on anyone.
It seems to be true.
Perfect. That was the goal, right?
You know what? I think this shows that you collectively had about the same effect as data has on improvement in healthcare. So you performed up to par. So, in all seriousness, absolutely in contradistinction to Donald Trump, you're all winners. I thought you guys were brilliant. They were inventive, creative. Please give them a big hand.